Great, thank you so much. So hello, Clomid virtual members. I would like everyone to give a warm welcome to our guest speaker, Dr. Ellen Wood. Dr. Wood is board certified in obstetrician and gynecology and is specialized in reproductive endocrinology and infertility. So we are incredibly grateful for this shadowing opportunity and hope to learn a lot today. As a reminder to our Club Med virtual members, if you'd like to have your camera on, we highly encourage it as long as you stay on mute while Dr. Wood is talking. There will be a survey given at the end of the session for Wayne State University students to obtain their shadow hours and attendance hours. To reiterate, only WSU students present today can receive hours. So we are also recording the session. So for anyone watching from YouTube, hello and thank you for watching. And I'm going to turn the session over to you, Dr. Wood.
All right. Hi. Well, thank you so much, Club Med virtual, undergraduate students for, being interested in this topic. This is a very niche-y type topic. So what I do is people will really, unless you do a rotation in it or experience infertility yourself, it's definitely something that is foreign to again, most people. Even obstetrician gynecologists who are practicing aren't sometimes even sure what we do. So what I have done today is I'm going to tell you a little bit about myself. Okay, let's see if I can make this work. Oh, come on. No, back there. This is a little bit about me. Okay. So basically what I'm an infertility physician. So what that means is that I did a 4-year OBGYN residency, and then I went on to do a fellowship in reproductive endocrinology and infertility. So, basically I delivered babies for 4 years, and then I learned how to make them, and then I went out into practice. Myself as a person, I'm an avid exerciser, marathoner, and I'm a mom of 2. I've got 2 girls. One of my daughters is a senior at Boston University. My other daughter is a postgraduate student at Philadelphia College of Osteopathic Medicine. The older one has got accepted into medical school, so she'll be starting in the fall. And then my younger one was accepted to Boston University Dental School, and she'll be starting there in a 1.5 years. She got early acceptance there. So again, this pre-med, pre-medical type of thing, undergraduate thing, I am well-versed. I am well-versed in it. And thank God my road is coming to an end. The next thing I have to stress about is residencies and fellowships. I went to undergraduate at University of Pennsylvania. My degree, interestingly, is not in the medical field at all. I did start off in college with a major in biology, and then I really didn't like the people in the biology program at Penn, and so then I changed to something called biological basis of behavior, because I thought the people would be more chill in that type of major, and no, those are the same people. And then I'm like, you know what? I really don't think I want to be a doctor. Like, these people are just way, way, way too intense. This is too difficult. I don't like this pressure. I want to, I want to just find what I want to do. So I completely changed my major when I was a junior, and I took all of my freshman classes and all of my sophomore classes, and I put them as electives. And I decided to get a degree in international relations. And what that is a combination of history, poli-sci, and economics, which I absolutely loved. So, I mean, after going out of all these science classes that I needed for my pre-medical school, I started doing like poli-sci. It was just a whole new world. So it was really, really wonderful. So my backup plan was that if med school didn't go well, I could use this degree and I could maybe go to law school. I also did a minor in Spanish, which is very helpful living in South Florida. So I have a very kind of atypical degree to, health majors and science majors. I got accepted out of college into medical school at Philadelphia College of Osteopathic Medicine. That's where I did my internship, my residency, and then I stayed in Philadelphia to do my fellowship. I started at Pennsylvania Hospital. Pennsylvania Hospital got bought by a very large hospital system, and they basically kicked us out of Pennsylvania Hospital, which had been a private hospital, and so I had to finish up my fellowship at Thomas Jefferson. After I finished my fellowship, I went into academics and realized that academics wasn't for me. There was not fast-paced. Academic practices do about probably 1/8 of the cycles that private practices do in the in vitro world, and I looked for a job in private practice. and we looked all over the country, and I had a job opportunity here in South Florida. So I moved from Philadelphia. I joined the practice in South Florida when I was 30 weeks pregnant with my second daughter. And I've been there ever since. So I'm 20 and a half years into my career in South Florida. Our practice, I was doctor number 4. We're currently 12 doctors with 6 offices, and our practice encompasses the whole southern part of the state. We have offices in Vieira, Jupiter, Boca, Cooper City, Miami, and Naples, and we're still growing. We're planning to hire more docs as time goes on, but it's a growing field. We're the largest practice in South Florida. So we just make babies. That's all we do. It's really, really fun. So I'm going to present to you a case, and this is a kind of a case. I'm just kind of going to go through it as the couple came to me. Okay. As if you guys were in the office, sitting behind me and just listening to kind of the intake. Last time too. Let's see. This computer does not like me at all. Okay, so basically the case in the day of a fertility specialist. So this is W, and this is her husband T, and this is going to be their fertility journey. Okay, so the first visit, they come in. She is a 28-year-old Jamaican female. She's a G1 P0, which means gravida 1, means she's had 1 pregnancy, and she does not have a baby. And because that pregnancy that she had was a miscarriage, it was a spontaneous conception that she conceived on her own, obviously, and it ended in a loss. She's been trying to conceive with her partner for the last 2 years, and they've been together for 9 years, okay? So after this pregnancy loss, she's not been successful. She says she was diagnosed with something called Polycystic Ovarian Syndrome when she was in Jamaica. So I'm keeping this in mind. I'm thinking, all right, maybe this is a part of their problem. So how important is this information? All right, so she's only 28. So does she really even meet, she's super young, does she even meet the criteria of infertility? And technically she does, because the definition of infertility is that if you are under 35 years old, you've had to have tried for over a year, okay? And then you're considered infertile, because 85% of the population, if you try for a year, they'll eventually get pregnant. So this is the patients who need to be referred to a subspecialist like myself. So yeah, she does meet the criteria because she's been trying for over 2 years. So she's conceived once before. So I got to keep this in mind. I'm not really sure how significant this is. Was this just a fluke that she had a miscarriage? Is this, and because why would a young girl who's 26 years old have a miscarriage? I mean, that's just a little funky. And then I have to also keep in mind, as I talk to them and get their history, like she was told she has polycystic ovaries. So is this something that could potentially be what's their problem? I got to ask her some more questions. So let's just first start off about PCOS, because this is something that is like super common. This is every day in the infertility world. It's one of the most common ovulatory disorders. It's a condition that affects about 1 in 10 women of childbearing age, and it definitely can impair fertility. However, no 2 women with PCOS have the same symptoms. This makes the diagnosis challenging. So some doctors will just hear a symptom and like, oh, you have this. But it also, it's not a one-size-fits-all diagnosis. Women with PCOS who wish to become pregnant are often really good candidates for fertility treatment. So if this is really her problem, okay, I have really easy treatments that I can recommend to her. So I'm still thinking that PCOS is like, I'm going to be able to help her pretty quickly. So what is the criteria? So what kind of criteria do we need for PCOS? So in 2003, okay, the Rotterdam criteria for diagnosis, and this was affirmed again in 2013, you need to have 3 things. Okay, so either we have 2 out of 3. So either you have oligo or anovulation. So either you're not ovulating on a regular basis, okay, so maybe you ovulate or get periods, let's say, because the assumption is that if you're getting a period, you're ovulating. That's the assumption that most of us make. So if you have irregular cycles, which would consider that they have oligo-ovulation, or they're not ovulating very much, oligo means few, or anovulation, which is not ovulating at all, or no period. So a lot of these patients with PCOS, they just present like they don't have a period at all. What was your last period? Oh, it was about 8 months ago. Okay, and you come to me and you wonder why you're not getting pregnant. So this is something that's super common. Then you also have to have clinical signs of hyperandrogenism. So that's the one picture down in the corner. It's basically you have to have hair under your chin. Some patients have a mustache. Some patients will have balding patches up here. Some patients will have extra hair growth on their chin. So you have to have some sort of physical sign or symptom that you have higher testosterone levels leading to these things that we see from hyperandrogenism. Then you have to have polycystic ovaries on ultrasound. So this is a surgical picture of an ovary. That's the big white thing in the picture above the lady with the chin hair. And that ovaries they're polycystic, they're like chubby ovaries. They're plump. I mean, I call them plump and juicy because they're filled with lots of little teeny follicles. So on ultrasound, when you look at these things, you're going to see them, and we're going to get to that in a second. But you also have to exclude other conditions. So you have to exclude congenital adrenal hyperplasia, that's CAH. You have to exclude androgen secreting tumors. So what if they have a tumor on their ovary that's making too much testosterone? That's why they have the beard and the alkyl ovulation. So these are very rare things, but you always have to keep them in mind in your differential diagnosis when you're seeing a patient. So, you know, PCOS is so common, a lot of times patients will just get labeled with this, and they actually may have congenital adrenal hyperplasia or androgen secreting tumors or Cushing's syndrome. Just always has to be in the back of your mind. I think I've diagnosed one of each in my 20-year career, so that's definitely not a common thing. But you always have to be thinking about it before you just do a knee-jerk, hey, this patient has PCOS or polycystic ovaries. Computer doesn't like me. Come on. Now it's gonna skip ahead. Oops. Did it skip ahead one? Yeah, see, I didn't wait for it. It's the computer. I'm not patient. Okay. So what this picture depicts, okay, is regular ovulation. So in the picture on the one side, it's basically we have a little follicle in the ovary. It grows, and around day 14 of a woman's cycle, we see a little egg pop out. After the egg pops out, then the yellow thing at the top is something called a corpus luteum cyst. And this is what occurs after the egg pops out. And this is a regular menstrual cycle. The menstrual cycle is going to be balanced between two hormones, okay? Estrogen in the beginning, progesterone at the end. So what happens is while that little follicle is growing, there's little cells inside it called granulosa cells. Those granulosa cells cause the estrogen level to rise, and it usually peaks around a level of 200 or 250. Once the anterior pituitary gland senses that the estrogen level reaches around that 200, 250, it says, hey, we've got a mature follicle down there. Let's send out an LH pulse. So the anterior pituitary gland goes, boop, sends out an LH pulse, and the egg gets released usually about 36 hours after the beginning of the LH surge. Egg pops out. Now comes the balance in the menstrual cycle. Okay, so where estrogen was dominant and rising in the beginning, okay, what happens now is the estrogen drops a little and the body starts to produce progesterone. So the whole cycle is balanced between estrogen and progesterone. Progesterone then comes out, it peaks 7 days from when the egg is released, okay? This is when implantation occurs. So if implantation of a pregnancy occurs, the corpus luteum is then given the food by the pregnancy and it stays making progesterone. If no pregnancy occurs, the progesterone drops and a patient gets a period. So you think about it like this. The estrogen basically builds up the wall in the uterus like a brick would on a brick wall. And the progesterone is like the cement that holds the bricks together, makes the bed for the baby. Okay, so this is the whole purpose of a menstrual cycle, okay, to all of you youngsters out there, is reproduction. That's it. There's no other reason to have a menstrual cycle, okay? I'm a big proponent of continuous birth control pills and no menstrual cycles. But anyway, some people like to have them. Why? I have no idea. Anyway, so on birth control pills, there's no reason to have a menstrual cycle. If you're trying to reproduce, you want the ovulation to occur. Now, with polycystic ovaries, okay, there's all these little teeny follicles in the ovary, but what are they all producing? So as a group, they're all producing estrogen. Estrogen, 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 estrogen. Since one follicle never grows big, we never have that LH pulse. We never have progesterone production. So what happens is in patients with polycystic ovaries, they basically build up a big brick wall. So there's all these bricks on top of each other. There's no cement. So once the wall gets high enough, patients bleed. So patients can even report bleeding on a regular basis if they're not ovulating. This is my world. So every once in a while they may kick out an egg, but in general, a patient with polycystic ovaries can get periods or infrequent periods, but they're probably still not ovulating because there's too many follicles in the ovary. And so what happens is, it's kind of like trying to talk to a crowd without a microphone. Your pituitary gland, okay, is sending these signals out to the ovary. If your ovary has a normal amount of follicles in it, it listens and it goes through the regular ovulatory process. But if it has all these little eggs in it, like with polycystic ovaries, doesn't pay any attention to what you're saying. You need a microphone in order to get the ovary to basically respond. So this is a picture of what polycystic ovaries look on ultrasound. Okay, so this is what I do every day. We just basically put the ultrasound in and see. So at least one ovary has to have more than 12 of these little teeny weeny follicles that are between 2 and 9 millimeters. And the best time to do one of these ultrasounds is between day 2 and 5 of a menstrual cycle if the patient has them. Then the ovarian volume, as I said, it's a very big chubby ovary. The ovarian volume is usually 10 millimeters in the absence of a cyst or a dominant follicle greater than 10 millimeters. So again, these are on ultrasound, these are very kind of chunky ovaries. So this is a more normal ovary on the one side and a polycystic ovary on the other. So normal ovary has follicles, okay? We can see the little black circles in the normal ovary. The polycystic ovary just has an excessive number of follicles, which is like gobs and gobs of them down there, which is, again, is a good thing. So if you gotta choose between having no eggs or too many eggs, pick too many any day. I mean, there's some challenges involved in that, but the amount of patients that I unfortunately see who have too few eggs is just day in and day out. And that's a situation where it's very hard to correct because a woman is born with as many eggs as she's ever gonna have, and they just genetically die off. And if you're 33 and you're out of eggs, I can't make them come back. So that's a very sad situation. So if you have to pick too few or too many eggs, go with too many. Even though it's not ideal, we can definitely manage this condition. So just a little bit more about PCOS. So patients with polycystic ovaries is like a syndrome, and that's why it's called a syndrome. They can experience metabolic syndrome, insulin resistance, high cholesterol, hypertension. They also are definitely at higher risk of heart disease, diabetes, and endometrial cancer. I tell this to everybody. Now, people don't come to me for a lecture on their health, okay? They come to me to make a baby, all right? However, I only have a limited amount of time to educate these people. So again, I'm talking to them about fertility. We're trying to figure out what's going on. But any patient who comes into my office who we definitely diagnose with polycystic ovaries, I stress these long-term health effects with them because I'm going to make their baby and send them on the merry way. But they have to be aware that if they don't have periods, their uterus is getting subject to estrogen every day from all these little follicles. And eventually that unopposed estrogen without a progesterone balance, endometrial cancer. Youngest girl I've ever had with it, 28. I had a 34-year-old probably 8 years ago who needed a hysterectomy because of endometrial cancer. So if you have polycystic ovaries, don't just say, hey, I'm saving on tampons, I'm not getting periods, okay? You're putting yourself at risk for cancer in the future. Because like, yeah, we have a lot of people, oh, I don't get periods, it's great, I save on tampons, I pay on pads. I'm like, no. Like I had a 40-year-old had a hysterectomy because of PCOS, endometrial cancer that I accidentally diagnosed. Like I get back a biopsy, I had no carcinoma. I'm like, no. I'm a fertility specialist. I only take care of healthy people. I'm like, my patients don't have cancer. No, she really did age 40, but it was from polycystic ovaries that just didn't pay attention. There's no cure for this, but many of the symptoms, again, they can be treated or managed with a combination of lifestyle changes and medication. So this is a syndrome. Again, I take care of the fertility part of it, but if people are going to go be generalists, they're going to do general OBGYN, even if they're going to do internal medicine, they're going to do family medicine, you're definitely going to come in contact with this condition. And you don't want to just, kind of blow it off. It's a condition that is, again, it puts patients at lifelong risks for chronic diseases. So back to our case. Okay, so what does W tell me about her period? So she reports irregular periods with long, heavy bleeding and maybe 5 or 6 menstrual cycles a year. So kind of going with the PCOS criteria, I mean, definitely kind of fits the picture. And she had used a fertility medicine called clomiphene citrate for 1 month in Jamaica. Okay, the doctor gave her that there, but obviously she didn't conceive. So what's Clomid? Like, what is Clomid? I mean, what kind of drug is that? Like, why would a doctor give her that? So what it is, it's an ovulatory stimulating drug, and it's used to help people who are having ovulation problems. It's one of the most commonly used fertility drugs. It's very, very effective, and it gets people to ovulate about 80% of the time. And in women who have irregular anovulatory cycles, again, menstruation without ovulation, Clomid may be tried first. It's often used in treating polycystic ovary related infertility. So this is a picture of my Instagram post, okay? So there's 2 drugs out there. So I compared in this post, I talked about 2 different fertility medicines. Which one's better? The Clomid is the one that I'm holding on the other side, and the other one is called Letrozole. Both of these drugs, okay, are what we consider to be anti-estrogens, okay? So Clomid acts like an anti-estrogen. And so what it does is it triggers the brain's pituitary gland to secrete an increased amount of FSH and LH. It stimulates the growth, then the FSH, because what's FSH? Follicle stimulating hormone, right? So it's going to get the little teeny follicles, those little guys that you saw in the ovaries, and on the ultrasound, it's hopefully going to get one of them to grow, because we don't want to invite everybody in the party, because I don't want to be Octomom doctor, okay? So we just want to get one of those little follicles to grow. Usually that's what happens with this type of drug. Only one grows. So basically what it is that your pituitary gland, as I said earlier, is talking to your ovary. Well, all it's doing is talking, and you have so many little follicles down there in your ovary, no one's paying attention. So what Clomid does, it basically gives your pituitary gland a microphone. It gives it a microphone so it can shout at that ovary and say, yo, one of you guys, let's start to grow, because we want to ovulate, and mom wants to have a baby here. So that's what the drug does. And it works great. I mean, it's one of our first line agents. However, the other drug, Letrozole, which we've been using, pretty much as first line now, okay, since 2014, it's a similar type of drug, also gives the brain a microphone, but it's an aromatase inhibitor. And so it's used mainly for breast cancer. So somebody has breast cancer, you use this drug, okay, as chemoprophylaxis for 2 to 5 years to prevent estrogen receptive cancers from coming back. So that's where the money is, okay? The money is not in fertility. We use 2 pills for 5 days. That's 10 pills. It's not 5 years of pills. So there's been no studies done on Letrozole by the company who makes it on fertility, okay? They just don't exist. We use it potentially off-label, okay? But it works great. So the enzyme aromatase is inhibited by letrozole medicine, and the estrogen is suppressed. And it makes the brain think estrogen levels are low. And then the brain, the pituitary gland, like with Clomid, increase the output of the follicle stimulating hormone. So in 2014, letrozole actually showed it has a higher live birth rate and ovulation rate in women specifically diagnosed with PCOS. So this has become the drug of choice. I think ACOG, American College of OBGYN, made it the recommended drug of choice as of I think the article came out in 2016. And so this is our mainstay of our treatment. Sometimes, again, if you're an OB and you've been in it for 20 years and you prescribe Clomid, you may not even be familiar with this drug, but it's what the fertility specialists use pretty much all the time. And Clomid is definitely something to fall back on, because not everyone responds to letrozole. Let's see. Come on, computer, let's go. Oops, no, okay. Okay, so back to our case. Let's talk about W. So I'm doing just a basic history. So all these things are going through my mind when I'm talking to her. So you guys are sitting behind me, watching me in the office, and I'm like, all right, let's ask her some more questions. So we asked her about her allergies. She's allergic to penicillin. We asked her about her medications. Now, she's taking a bunch of medications, okay? She's taking Metformin, 1,000 milligrams twice a day. She's taking norethindrone, 5 milligrams. Now, what norethindrone is, as I told you guys earlier, patients with PCOS have a dominance in estrogen, but they don't ovulate, so they don't have any progesterone, okay? What norethindrone is synthetic progesterone. So basically, I call it uterine glue. So this is the mortar, this is the cement that holds those bricks together. So this patient says when she bleeds, she just bleeds and bleeds and bleeds and bleeds and bleeds. So basically her entire uterine wall just keeps falling out. And so she's taking this pill that was prescribed by, I think, her OBGYN to try and stop her from bleeding. So again, it's a synthetic progestin, acts like progesterone, but it can stop the patient from bleeding. She's also taken pravastatin. Okay, this was not a good idea. And as soon as I should have, she jumped on pravastatin. I was like, yo, you're 28. Why are you taking a cholesterol medicine? She's like, oh, they told me my lipids were high. All right, category X in pregnancy. So birth defects, we need to stop that right away. So this is why we go through the meds. And she said she'd stop it that day. She wouldn't take another pill until, after she has her baby. But it does cause birth defects. So this is why mainly family practitioners and doctors do not prescribe, usually, young women or reproductive age women statins because they cause birth defects. She's taking iron. Obviously, that's the COVID FeSO4, but to improve her anemia because obviously she's a little anemic because she's bleeding all the time because she's not having regular cycles. She's taking a prenatal vitamin. The prenatal vitamins that I prefer, any patient who's trying to conceive, if any of you are trying to conceive in the future, your prenatal vitamin should have methylated folate in it. Methylated folate is the most absorbable form of folic acid. Folic acid is necessary to prevent neural tube defects of the baby, okay? Some patients have an enzyme deficiency where their body's not able to absorb a regular folic acid or absorb regular folate. Methylated folate will go right into your system and you don't have to worry about having an enzyme deficiency. And then she's also taking fish oil. Okay, so what is metformin? Oh, I pressed the button, it's not gonna go. Let's go, come on. Let's see if it goes. So what is metformin? So metformin is a common medicine used to treat patients with PCOS symptoms. It was originally developed to treat type 2 diabetes. It's one of the oldest and most studied drugs in the US. It's known as glucophage, glucophage XR, Glumetza, Forimet, Riamet, lots of different forms of it. But basically the generic is like free at Publix. So most people will just get the generic metformin now. But it's used to relieve insulin resistance in women with PCOS. So women with PCOS are, again, predisposed, as I said earlier, to metabolic syndrome. So metabolic syndrome is that heart disease, the high blood pressure, things like that. And it's because insulin acts like sandpaper. It just rubs against your insides and causes inflammation. If you can lower the insulin levels, you're going to have less inflammation. And the ovary is going to be more sensitive to the drugs I prescribe, like either the Clomid or the metformin. So insulin resistance goes hand in hand to PCOS. Okay, not everybody, but the majority of patients will have this. And so what insulin is like, so remember we talked about the ovary has all little follicles in it, okay? And so it's like, they doesn't listen to what the pituitary gland does. Now, if you put insulin on top of it, insulin acts like a little soldier. And it's like a little soldier that surrounds the ovary and like protects it from the signals that the brain sends out. So if we decrease the insulin level, we get rid of the soldiers that are holding the ovary hostage from ovulating. So all of these things in PCOS, they all kind of work together. So it's the key feature in both obese as well as lean PCOS patients. So most people with PCOS, you'll see they're, sometimes we think about them all obese, but the insulin resistance it occurs in 70 to 95% of people with obese PCOS, and then 30 to 75% with lean PCOS. So you can be skinny and have polycystic ovaries. High insulin level is not just a symptom of PCOS, but again, it's a major, major driver of the condition. It can impair ovulation, little soldiers around the ovary holding it hostage, and it can cause the ovaries to make excess testosterone as well. So a little bit more about her history. So let's talk about her history. So her past medical history, she's been diagnosed, PMH, has been diagnosed with PCOS. She's also been diagnosed with hyperlipidemia, which is why her doctor gave her the pravastatin. She's also been diagnosed with type 2 diabetes, but she's planning, when I talked about the diabetes, she's like, I'm starting a new diet, my new health insurance, I'm gonna get the diabetes under control. I'm just a little bit above the diabetes level, and my doctor wanted me to, because of the PCOS, start me on the metformin, and maybe it'll help my diabetes as well. And she also reports an anxiety disorder, which she doesn't take meds for. Surgical history, she denies. Social history, denies. Family history, very common. Her mother had diabetes. Her sister has hypertension. So again, this is like a syndrome, and it does run in family. There is a genetic predisposition to it. She sees a OBGYN. Her last PAP was 2 weeks before she saw me. And she was diagnosed with BV, or bacterial vaginosis, which has nothing to do with fertility. Her last period was in September. Long, heavy bleeding, very, very irregular. And she is a student and an English tutor. So that's done. We're done with her history. So now let's talk about her hubby. So T, he's 27. He had the spontaneous pregnancy with her. His history is pretty boring. Okay, he's not allergic to anything. He doesn't take any meds. Doesn't have any medical problems. He never has any surgeries. He doesn't drink or smoke. Father did have diabetes, but I don't think that's contributing to infertility. And he's a cable tech for Xfinity. So on physical exam, so now we've talked their history. Now I'm going to take them into the room. I'm going to do an examination on her. So physical findings in polycystic ovary patients include androgen excess, which we talked about, insulin resistance, and the presence of extra estrogen. So normally they're obese. I mean, again, you can't have lean PCOS, but in the majority of patients, again, we see an obese patient with irregular cycles. You just like knee jerk, oh, she has PCOS. So our patient is obese. She's 267 pounds. Sometimes polycystic ovary patients have elevated blood pressure. She's kind of young, so most of my PCOS patients in their 30s, they've developed that high blood pressure, but her blood pressure was 129/80, so she does not have high blood pressure. Some patients, again, if they have insulin that's high, you're going to get this hyperpigmentation of the skin, okay? So on the back of your neck, like right here, you get these brown patches. Like you can get them under your arms, under your breasts here, definitely on your inner thighs. Sometimes excess signs of estrogens are going to be excessive body hair, like with a male pattern distribution. Patients will have acne, and acne is very, very common in polycystic ovary patients. Our patient, when I examined her, she just had dark patches on her inner thigh, but no real evidence of what we call acanthosis nigrans on the back of the neck. PCOS patients on the abdomen usually will have abdominal obesity, which she did have. So I did her ultrasound. Okay, so this is her ultrasound. So her lining was thin. Okay, that's up in the corner up here. I'm afraid to use this mouse because my slides may advance. But up here in the corner, she's a thin lining, but that's because she's on progestin, and so her progestin's kind of keeping her lining thin. These are her ovaries. Interestingly, these are not typical polycystic ovaries. So now I'm like, but she does meet criteria. She does have a little bit of the testosterone. She does have the irregularity in her cycles, but the ovaries are not classic PCOS. So what's my impression? So after I talked to them, I'm like, PCOS, mild, if anything. She has irregular bleeding, so I want to think about an anatomical lesion, but the lining was thin, but I'm thinking polyps. Maybe she has polyps in her uterus. She definitely has, what she's told me, has NIDDM, non-insulin-dependent diabetes mellitus. She has her elevated LDL, so I'm telling her to stop her statin. That's like an absolute. So what am I going to order on her? So that's my impression right now. My plan, I'm going to get what we call preconception labs. I'm going to check a lipid profile, see where she is if she really needs the statin. Like, I mean, if her cholesterol is like 300 or something, like, maybe we shouldn't be having a baby. I'm going to check a test called SEMA4, which is a genetic test to see whether either one of them carry a genetic disease like sickle cell. So I have this unique opportunity to test and see patients before they become pregnant. So I can test her and see if she carries sickle cell gene, and I can test him to see whether he carries sickle cell gene. If they both carry the gene, now they know before they even get pregnant that their baby might have a 25% chance of having sickle cell disease. This is kind of good information to know. Most people will show up at the OB, they're pregnant, they're thrilled, they're excited, they're 10 weeks pregnant. Now the OB checks them for sickle cell. Oh, you have sickle cell. Has your husband ever been checked? No, he's never been checked. Well, let's check him. Then you check the husband. Oh my gosh, the husband has sickle cell. And then they says, doc, what does this mean? Like, what does this mean for my baby? Well, we don't know. Your baby has a 1 in 4 chance of having sickle cell. Well, what do I do? Well, so do you just want to take the chance and deal with a sick baby, or be less prepared for it? So you need a CVS or an amnio in order to determine if the baby has the disease. And then, again, sickle cell is a disease you can live with. It's just pretty awful. But again, you would have the option if you get the amnio or CVS done early enough to potentially terminate. I also checked a B12 level on her. Now I'm going to order a couple other tests. I'm going to order an HSG. HSG stands for Hysterosalpingogram, which is going to be a check of the fallopian tubes. I'm going to order a Sono HSG, which is a water ultrasound, to look for polyps. Polyps are growths in the uterus that might be causing irregular bleeding. I'm going to order an SA or a semen analysis. I'm going to get male blood work, and on him, I'm going to get the SEMA4, okay, check for genetic disease. And I'm also going to get hepatitis B, C, syphilis, HIV. Then after I get their blood back, I'm going to bring them in for a consult, and I'm going to have the patient stop taking her progestin and start taking a fertility medicine once I know they are healthy enough to become pregnant. Let's see where this wants to go. This computer is very, very, very. There we go. Okay, so this is the results of her preconception panel. So she has an AMH. AMH stands for anti-Mullerian hormone, and this looks for your pool of eggs. Her AMH is 2.58. not really polycystic. So we have averages on women who have polycystic ovaries. So if you're 28 years old, your AMH level should be around 3.5 to 4. So she's actually a little low. So we think a polycystic ovary patient would have more eggs. I would. I mean, that's common. It's not a part of the criteria. But normally in patients with polycystic ovaries, we'll see levels like 14, 20, 25, like ridiculously high levels. So her PCOS diagnosis is still a little suspect, but she definitely has an ovulation problem based on her irregular periods. Her blood type's A positive, her hemoglobin's 11.4, so slightly anemic. Her cholesterol is only 184, but her LDLs are a teeny bit high. They're at 133, 130 being the top normal. Vitamin D is a little low at 30. And this is her report from her expanded carrier screening. She does not carry any of the 283 genetic diseases that we tested for. Okay, so not her blood and her blood count. I mean, everything looks pretty good. So this is his semen analysis. Okay, so we checked his sperm. He's got a count of 200 million. Like that's ridiculous, like excessive. So you know, he's got sperm. So what we look at on the semen analysis is we look at here the concentration. Normal is 39 million. He has 200. Count. I mean, motility is 65%. 40% is normal, and then normal forms is 4%, and 4% is normal. So this is a absolute perfect semen analysis, like no issues on the husband's part. This is really an absolutely perfect semen analysis. So what this is her other test, her hysterosalpingogram. So this is her uterus here. It's a little kind of folded over. It's kind of retroflex. And the dye, this black stuff here, this is the dye going into her fallopian tubes and out. The picture on my Instagram today is a little better than this picture. But anyway, this was actually her picture. So I wanted to kind of keep it like the real case that we're doing here. So that's what we got on that. Then I did a water ultrasound on her. Come on, water ultrasound. Let's go. Come on. Nope. There's a water ultrasound. Okay, so damn it. Okay, this is the results of her water ultrasound. So I put some water into the uterus and I looked at the walls, and the walls here are all smooth. There's no growths or polyps or any lesions inside the uterus. So even though the x-ray gives us a contour of the uterus, the saline sonogram gives us a little better because we can kind of turn it around. I use a 2D machine. A lot of reproductive doctors use a 3D machine, which makes it a little bit more accurate. I find 2D is fine. I was trained on it. I like it. But I don't see any lesions in her uterus. So in summary, so now I brought them back and we're following them up with a Doxy telehealth consult. Okay, so I'm reviewing all the results. So we've got a saline sonogram that was normal, an HSG that was normal, an AMH level that's not really consistent with polycystic ovaries. We have a hemoglobin of 11.4. She's already taking her iron. Vitamin D is 30. I really like it around 40 or 50. So we're going to recommend that she take 5,000 of vitamin D a day. And she's taking the Agestin, which is the norethindrone, and that I increased her dose from 5 to 10 milligrams. His body has stopped. We did the telehealth because she had COVID. So this is real. So that's why the telehealth. So I told her once she's cleared from COVID, then she can stop her progestin and get her period. And then we're going to start her on Letrozole. So Femara is just how this is. I just wrote this because this is like, and you're supposed to be shadowing. This is exactly how I write it in the office. So Femara is the shorter name for Letrozole. And so that's why I write it in my chart, because it's shorter to spell. So we're going to start her on Femara, 5 milligrams. She's going to take 2 pills for 5 days. And then she's going to come monitored on the 12th day of her cycle. If the follicle is mature, we're going to give her HCG, which mimics the body's own LH surge. Then we're going to tell her when to have sex. We're going to check her progesterone level. That's what's called mid-luteal progesterone, or MLP. Okay, 1 week later, and then we're gonna do a pregnancy test. We're gonna try this twice. If she's not pregnant, even though he's got like ridiculously good sperm, we're gonna add IUI, or intrauterine insemination, and add some sperm into the uterus, because maybe the boys, even though there's a lot of them, they can't find their way. So this was her baseline ultrasound. So she stopped the hormones. She came in and her lining was thin, as we expected. Ovaries, again, we see about 5 follicles here. This ovary is looking a little bit more polycystic in this picture. Still not classic for it. So this is her baseline. We now prescribed her 2 medicines, Letrozole and HCG. So here she comes back. This is monitoring day 11. okay? Lining's getting a little thicker. We're starting to see this what we call a triple stripe pattern. Follicles are getting a little juicier. I mean, you can see them kind of plumping up here, and we can see one right here down in the bottom in this left ovary. It's kind of breaking out of the pack. It's getting ready to maybe ovulate. Now, this follicle is still small. I didn't have an ultrasound of the size, but it's about a 14 millimeter follicle. Follicles grow 1 to 2 millimeters a day. So once it's going to hit a 20, that's when we're going to be able to say it has a mature egg. So we brought her back on day 15, and here's what we saw on day 15. So her lining is even thicker. It's getting a little plumper. Right ovary, yeah, the follicles are starting to plump up. And here we go. This one on her left, it's broken out of the pack. It's that one follicle that's paid attention to the brain signals. So this is day 15 of her cycle. It's measuring about a 21, I believe. That's I didn't put it on it wasn't on the picture. And now we're going to give her an HCG shot. So now we're going to give her this shot. So boom, my nurses give her the shot. We're going to say, hey, you need to have sex a minimum of twice in the next 48 hours. So we saw the mature follicle, a treatment plan. We injected her with the Ovidrol, which is HCG. Ovulation should occur within 36 hours. This is her fertile window. So she wants to have sex. We recommend she has sex at least once before she ovulates, and then again while the egg is in the fallopian tube. Then we're going to check her progesterone level. Now, this progesterone level is pitiful, okay? This was 1 week after ovulation. We really want this level to be 15 or more. 4.5 says she ovulated, but it's really a stinky level. So I'm thinking there's no chance in hell that this poor girl is getting pregnant, and her ovulation is terrible. So we started her on progesterone support. Because progesterone, as I said, it's going to glue the bricks together. It's going to make the bed for the baby, okay? It's going to make it nice and thick, and like a nice home, so the baby can, kind of bury its way down in there. So we started her on progesterone, and we have a pharmacy that gives it to them same day. We get results back same day, so we're not missing our window of implantation. So again, we kind of reviewed this a little early with the basics of the menstrual cycle. So here's the estrogen, it rises, the follicle pops. Here's the progesterone, it's supposed to peak a week later, again, day 21 after the cycle, and we want it to be 15 or more. So a week later, we checked a pregnancy test. She's pregnant. I mean, it was like the most wonderful, I'm a goddess to her, okay? First cycle, I get the lady pregnant. So her beta comes back at 42. Her progesterone has jumped up, that's P4. Her progesterone has jumped up to 18, and that's from the suppositories. Estrogen's a little low at 74. We like it because the estrogen now has to be made by the ovary too. Estrogen has to be, we have to support that for the pregnancy. So we gave her some estrogen patches just to bump that up. So 2 days later, we checked her pregnancy test. It went from 42 to 201, okay? And her estrogen bumped up to 201 as well. We want to see the beta level double. Okay, so if it's 42 minimum, we wanted to see doubling is 84, and then the next day we wanted to see it, 170 or something like that. She even over exceeded she went to 42 to 201, and then 5 days later, because I think there was a weekend involved in there, we couldn't get the blood, it went up to 1,203. Once the beta hits 1,500, we should be able to see a baby on ultrasound. Okay, so we follow it to make sure that the pregnancy is growing well in its early stages. We are complete overkill. We're subspecialists. OBGYN say, hey, you have a positive urine pregnancy test, come see me at 8 or 9 weeks pregnant. That's not the way we work in our office. So she comes in, we schedule her for OB ultrasound after her betas went up. So what this circle here is yolk sac, and it's a little teeny weeny thing, and that is her baby. It was super, super, super early. She was a little under 6 weeks in this ultrasound. And then we brought her back, and this is what we saw, success. So now we have a heartbeat. This is the baby right here. Heartbeat of 165. The pregnancy has been growing beautifully. So basically, patient was here. This is my note from the visit. She got pregnant in her first femara with intercourse cycle. Her MLP was 4.5, but it went up to 18 after we added support with her first positive pregnancy test. She did have a little episode of bleeding where she ended up in the ER, came in to see me. We usually discharge them at 8 weeks, so she's 8 weeks, 4 days. Her due date September 2021. Heart rate was 165. She had a corpus luteal cyst, that yellow thing I showed you guys on the menstrual cycle chart. So that's where she ovulated from on her left ovary. She's still taking her metformin. Her blood sugars are controlled. She's on her patches that were estrogen patches because her estrogen was low. We're going to continue that till 12 weeks. We're going to continue her progesterone until 12 weeks, and she's going to continue her prenatal vitamins. So this is why I love my job. Okay. I mean, this is just like, it just doesn't get any better than making babies. I mean, taking them out is really fun too, but again, you get to sleep more in my job. So, it is just super, super fun. So a little just word of advice for all you undergrads. if you want to be a doctor, never give up on a dream just because of the time it'll take to accomplishment. My last medical student that I had last month, she undergrad, she applied, she got rejected the first time. She had been a scribe, she scribed for another year. People were telling her like, oh, be a PA, be a nurse, be something different. And she's like, I want to be a doctor. So it's a long road, but if you find that, find that that's what you want to do, it's really, it's an amazing profession. I mean, I love what I do. So if you love what you do, you'll never work a day in your life. Anyway, so thank you everybody for attending. Hopefully I kind of tried to stay into my time constraints here. I am on Instagram at Dr. Ellen Wood. I'm apparently now a TikTok sensation. Not really sure how that happened. Apparently my post for Monday morning, I'm up to 3.1 million views, which I don't really understand how that happened, but I didn't think it was that clever of a post. But anyway, I'm also on Facebook at Dr. Ellen Wood. My email address, if anyone has any questions about anything, again, my job, any advice, I'm at Dr. Ellen Wood at ivfmd.com. And that's my office number. So I'll be more than happy to take any questions that you may receive. I'm not sure if you see them, Mariana, tell them to me because I don't have the little question thing. I'm not really sure how to get it. Anyway, thank everybody for listening, and anybody on YouTube or anybody who listens to this after the recorded session. I'm just here to answer if you have any questions.
Yeah, so you guys can post your questions in the chat and I can read them out, or you can unmute yourself if you'd like. I know I talk a lot, so if you want to raise your hand, you can interrupt me. I had a question. So did you ever consider another specialty, or was it kind of like set in stone for you?
Yeah, so interestingly, as I said, when you go into medical school, you kind of like, you do rotations, okay? And the rotations are kind of give you a taste of the specialty. So my father wanted me to be a ophthalmologist or a dermatologist. Like he was adamant about this, like adamant about lifestyle. So I think my first rotation was psychiatry. I forget my second one was. My third rotation was OB. I went and I did my OB rotation and I didn't even think I'd like it. The first night I was on call, the first year resident let me do a bed delivery. This lady was in labor. She'd had a couple babies and he's like, do you want to do delivery? And I'm like, sure. He let me do a bed delivery. She had like a tear. And then he handed me the needle driver and let me sew it up. And he taught me how to do it. I was like, this was my first to third year student. Like, that was such a rush. Like delivering babies is really a rush. It's so much fun. So I'm thinking, oh my gosh, I want to do this. So I do the whole rotation. I'm like, I love this. Every single night I come home, I live with my, to save money, live with my family. He's like, my dad's like, no, you want to be an ophthalmologist. You do not want to be an obstetrician. I'm like, okay. So I ended up doing two ophthalmology rotations and 3 dermatology rotations, okay, to try to convince myself I did not want to be an OBGYN. Nope. If I saw another eyeball, like if I saw one more cataract surgery, it was just awful, okay? Dermatology, one more wart, that's all they did was cut off skin cancers and freeze warts all day long. I just couldn't stand it. I mean, then we did 2 weeks of ENT. Oh my God, mucus. I mean, it was just, I mean, there's certain specialties that you go and you do them and you're just like, I could never do this. But I loved OB. And so finally I won. Dad, I'm applying to OB. And he's like, shaking his head. Oh, you're going to regret this. And I'm like, not really, because it's fun. I mean, I loved my residency. Absolutely loved it. However, my husband at the time was also an OBGYN. So this didn't really make for like easy for family. If I'm on call, he's on call, who's going to take care of the kids? We wanted kids. Like it just wasn't easy. So I said, look, one of us is going to have to be a subspecialist. So at the time, there was only 3 subspecialties for OB. There was gynecological oncology, there was OBG, there was maternal fetal medicine, and then REI, reproductive endocrine and fertility. So I said, look, you do the REI rotation, okay? There's a spot open. We may be able to get it if they like you, blah, blah, blah. So we send him off to do the REI rotation. Literally, he comes back every day of the rotation. Hate this. I'm like, no, you're not allowed to hate this. No. You need to be a subspecialist. So maternal fetal medicine wasn't an option because you still delivered babies. So that didn't help that didn't help the situation. And then oncology, it's amazing surgery, but people die. And that's just sick people and people dying. It just is really, it's depressing. I mean, the surgery is amazing, but it's the death is not fun. So I said, all right, let me see. Maybe I'll like infertility. I wasn't even considering infertility. This was not my lifelong dream. I went and I did the infertility rotation. And after the first week, I'm like, this is so much fun. I love this. I love playing with hormones. I love manipulating the menstrual cycle. This is awesome. So that's how it came to be. But it was one of the best decisions of my life. And I think I actually have a better job than the dermatologist or the ophthalmologist doing it. So it was just but that's what you do. You just kind of like do things, you just kind of cross them out and you say, nope, don't like that. Nope, don't like that. Nope, don't like that. Do you have any other questions?
So someone sent me a question. So they said Dr. Wood mentioned birth control, and I'm wondering if there are any long-term negative effects of prolonged birth control use, such as trouble with fertility, pregnancy on the road after coming off birth control or otherwise.
Birth control is the greatest thing if your body tolerates it well. Okay. Number one, decreases your risk of ovarian cancer significantly. Okay. Number two, decreases your risk of endometrial cancer significantly if you have polycystic ovaries or in general, if you have any type of irregularities in your cycles. So they're the two big things. Then continuous birth control without periods actually will slow the growth in case you have a predisposition towards endometriosis, which is a terrible disease to have. It contributes to lots of women's infertility. It will slow the growth of your endometriosis, and actually you will be more fertile after stopping the birth control pill. So in those respects, it has super great pros to it, okay? Some women can't tolerate it, and that's really the only con. There is no reason to get a menstrual cycle unless you want to reproduce. Now, some people think that if you take the birth control and you're not ovulating, this will affect your fertility. Absolutely not. However, it's not going to save up your eggs. So I had a question the other day from a patient. Well, I was on birth control for 10 years. Do I have more eggs than other people who weren't on birth control because I didn't ovulate for 10 years? Nope. It's use them or lose them. So you have 100 eggs that step up to the plate 1 month. If you don't ovulate, then those 100 die. 100 eggs step up to the plate, they don't die. They still step up to the plate when you're on birth control. So you're just going to be genetically predisposed to losing your eggs whether you ovulate or not. But again, the health benefits of birth control really outweigh any type of side effects. Now, there is one side effect of birth control that we all have to be aware of, okay? These are hormones you're taking. And if you're taking hormones, it can make your blood thick. So if you smoke, okay, which nobody should smoke because nicotine kills your fertility, and women who smoke go into menopause 6 years earlier than women who don't smoke. But if you smoke, it's going to make your blood too thick, and you could put you at risk for pulmonary embolism, deep vein thrombosis, clotting problems. We don't prescribe birth control to patients who are over 35 that smoke. It's contraindication. But if you're young and you smoke or you vape or you do anything that can make your blood thick, yeah, birth control, yes, you could have some negative side effects from the birth control. But the gynecologic health benefits of lowering the incidence of endometriosis growth, endometrial cancer, ovarian cancer outweigh anything. But you shouldn't smoke anyway if you're thinking about babies in the future. So again, I have again, as I said, I've got 2 female children and they are both on birth control. I encourage them to take it continuously because again, they're not ready to get pregnant. So there's no real reason to have a period unless you're trying to get pregnant. And the blood doesn't build up. That's just not a thing. It's impossible because of that opposition between estrogen and progesterone. It keeps the lining thin. People are like, don't get a period. My uterus is all filled with gobs and gobs of menstrual blood. No, that's not the way it works. Other questions?
Yeah, we have 2 in the chat. So someone asked, do OBGYNs recommend IUDs or birth control more? I'm going to guess they meant the pill.
Well, again, so the pill is just easily reversible. IUD is kind of expensive, and when you put it in, you either put it in for 3 years, 5 years, 10 years, okay? So we'll put IUDs in patients, and there's 2 types of IUDs. One IUD has no hormone in it, the other IUD has hormone in it, and the IUD with hormone in it is good for patients who have, heavy menstrual cycles. and stuff because it keeps the lining of the uterus thin. But IUDs are nice for patients who can't take hormonal contraception, because some people can't take it due to other type of medical conditions. So yeah, we love IUDs. I mean, like if somebody wants to not have their babies anymore and they want to get the tubes tied or get the tubes removed, they want to have babies, okay? And you think that this woman after 2 kids, she may change her mind and there's a lot of regret from tubal ligation, you beg her to put an IUD in because it's easily reversible and it's really great birth control.
And then we have a question from Noor. They asked, how can a patient with PCOS stay healthy in the years before she decides to try conceiving?
Make sure you're having periods. So most patients who have PCOS and they don't want to have a baby, birth control. Birth control helps with acne, it helps with hair growth, it increases sex hormone binding globulin and binds up any excessive testosterone. Birth control is the best thing. Now, some people can't tolerate it. So if you can't tolerate birth control and polycystic ovaries, you should be taking monthly progesterone. So if you're not getting your periods, you take a progesterone called Prometrium for 10 days, usually from the 1st to the 10th day of your cycle to get your cycles, because you have to keep that uterus healthy. As I said, I had a lady 28 years old. She did PCOS, didn't like having periods. Just like, God, I haven't got a period in a year. And she was a smart woman. She was a nurse practitioner. And I'm like, you need to have periods. And she kept growing things in her uterus because of the unopposed estrogen. So the best thing with PCOS is before you want to have a baby, just use birth control. It is literally easy, well tolerated, regular cycles. You prevent that endometrial cancer. In some patients who are insulin resistant, okay, we'll have them on birth control and metformin together, okay? And that's, again, for long-term health benefits. Because if you are insulin resistant and you have those elevated levels of insulin that are scratching your insides, I mean, years and years of that, this is what leads to syndrome X, hypertension, cardiovascular disease, all of that stuff. So a lot of patients who really want to be proactive, get insulin levels checked, irregular cycles of birth control, but the combination of metformin and birth control pills is really one of the safest things that PCOS patients can do to protect their health for the future.
Great, thank you. I'm going to take one more question before I give out the closing statement, but if you're able to stay after, and if you guys, I don't know if you're able to, because I'm sure you're busy, but if anyone has any questions, are they allowed to email you or?
Sure, absolutely.
Awesome. So somebody asked, what happens if you stop taking your birth control pills?
Okay, well, it depends. I mean, if you stop taking your birth control pills, you should get your periods back, okay, within 4 to 6 weeks. So you should become ovulatory again. But obviously, they're working to suppress ovulation for birth control. So most women, okay, they'll stop birth control, and within 4 to 6 weeks, normal menstrual periods will resume. That's just so. It just, I mean, if you're polycystic ovaries, they may or they may not. So the first thing that I tell my patients who they come to me, they're like, okay, Dr. Wood, you have me on birth control since I was 23. I'm 28 now. I want to have a baby. I'm like, what should I do? I look at them, I go, stop your birth control. And they're like, okay. I said, if you don't get a period in 6 weeks, come back and see me. And I have many of them that stop their birth control. And actually, I don't know whether it's a rebound effect or their polycystic ovaries aren't as bad now. And they're pregnant. Like I've had them like not get a period because they've ovulated, they've had sex, and they've gotten pregnant. So most women's fertility will resume pretty quickly.
Okay, awesome. Well, all right, guys, thank you so much for attending, and thank you for this shadow session, Dr. Wood. I think our members learned a lot today. I know I definitely did. And I also appreciate it when people talk about fields that are not quite as well known. And I hope to host a session with you again in the future. So I know you posted your social media handles in the slide here. So if you guys want to take a screenshot, or I don't want to ask you to post it so you don't have to leave out of the slide, because I know that can get messy. But to our WSU students, if you could please fill out the survey posted in the chat to obtain your shadow hours. Thank you guys so much, and I hope you all have a great night.